And joining us now on this episode of Pioneers is Dr. Peter McCullough, also not a stranger to trial site news. Dr. McCullough, thank you for joining us. And for anyone who doesn't know you yet, a brief introduction.
Well, thanks for having me. I'm a practicing internist and cardiologist in Dallas, Texas. I'm also trained in epidemiology. And Dallas, Texas is relevant to this discussion of Marburg because a related filovirus, Ebola. In fact, there was an Ebola outbreak in Dallas, Texas several years ago and was well managed by Presbyterian Hospital as well as CDC officers who came. And, I can tell you that the Marburg virus and related Ebola have basically been involved in sporadic outbreaks since, certainly for Marburg, since the 1960s. And the outbreaks each and every time have been sporadic. They haven't taken on the countenance of global pandemics like SARS-CoV-2. And, I'm interested, I'm sure as Dr. Stone is, in because the cases are so few and the outbreaks are so limited that we really need to focus on treatment, empiric treatments, and it looks like there's a variety of things that are hopeful. So I also question with Ebola, Marburg, and even with the monkeypox scare that we had earlier on, I question the mortality rates from some of the African countries that are in, that may not have the same type of critical care, ICU care that more developed countries have. So when things are given a very high mortality rate, the next question is, how do they actually die? And was that supportable in an ICU environment? And in the Dallas experience with Ebola, we did have some deaths, but in fact, some of the nurses who contracted it survived just with good ICU care.
Right. And one of your quotes in that article on Courageous Discourse is, "I can tell you as a doctor, I will refuse to sit in lockdown and wait for a vaccine. The world has concluded we cannot vaccinate our way out of future outbreaks with untested, unsafe genetic vaccines. Hence, our focus will be treatment, treatment, treatment." One of those treatments that seems to be emerging on the subject of Marburg. But isn't it interesting that anti-malarial drugs seem to be related to treating these kinds of diseases? Your thoughts on why?
We've been interested in any of the types of drugs that work inside the cell. So the anti-malarials do that. There are some antibiotics that actually work inside the cell. And any of these types of treatments, because they could influence replication of a virus, for instance, also influence intracellular mechanisms that either are working for cell-to-cell transmission of cytokines and inflammation, or actually triggering cellular mechanisms of defense. Any of these types of drugs are very, very attractive. We know that with most of the biological threat development that's going on worldwide, there's a much greater interest in monoclonal antibodies, for instance, which is an extracellular approach. Monoclonal antibodies theoretically could intercept a foreign invader if it's in the plasma. But I can tell you that with these viral infections, the hardest thing to know is, when did the infection start and how invasive is it from a systemic perspective? And for those reasons, I do think the drugs are going to always beat other types of pandemic response measures, particularly vaccines. Vaccines could only have a role if they were safe in terms of preventing the acquisition of disease, in a perimeter of at-risk individuals. Here, the outbreaks are too sporadic, they're too small. Vaccination wouldn't have any role.
I have two more questions for you. I know you've got a patient shortly, and the one is it plausible that mRNA in the food or water supply is leading to symptoms that are sometimes being mistaken for Marburg, Ebola, or some other condition?
Yeah, I don't think that's likely at this stage, but there's great concern now that there is messenger RNA in the food supply. A recent paper by Zhang and colleagues was able to get a restricted segment of genetic code, messenger RNA code, for the SARS-CoV-2 spike protein in exosomes made from milk, essentially milk bubbles, and then we're able to have them cross the GI tract in mice and effectively immunize the mice from a gastrointestinal perspective Now a review of veterinary products in the United States shows that there are genetic products widely used in porcine or basically pigs for that form of livestock, and they're clearly on the way for cattle and beef. So there have not been safety studies to demonstrate that there is not transmission of the genetic material from the meat into humans. On my Substack, I review some of the available reviews on transmission. The hope is that with curing and cooking of pork, that in fact the RNA would be denatured, degraded, and wouldn't be an issue. But the beef supply, fish supply, and then fruits and vegetables are very worrisome because there's a variety of cooking techniques. A lot of people may not know this, but in the Middle East, for instance, high quality beef is considered a delicacy, and it's eaten raw in some preparations. United States, here in Texas, they love their steaks rare or medium rare. And so the cooking is not as thorough through the meat. And now that we understand that RNA, certainly messenger RNA, that is pseudo-uridinated, has the nucleoside analog caps in place, that it actually can be absorbed through the mammalian GI tract, and we anticipate human GI tract. We're at a whole new level of concern. Tomorrow there'll be debate in the Missouri House of Representatives for a transparency bill, Bill 1169, that will begin to force farmers and food suppliers to label food that has been manipulated by genetic injections, RNA, DNA.
We will certainly be keeping an eye on that. Of course, the health implications are certainly going to be significant. Dr. McCullough, 3 years into what some people still call a pandemic, and never before has the world and the public and the healthcare field in particular been more aware of the failures within the WHO, incompetence, conflicts of interest, corruption, lack of transparency, etc. What do you think the public should do and the healthcare workers should do the next time the WHO issues recommendations, whether it's on Marburg or the next disease outbreak in inverted commas? What should we do? What are our choices?
The action on the table in the United States is called Sovereignty Coalition. Sovereignty Coalition led by attorney Reggie Littlejohn. And it is basically a call to pull out of the WHO. The WHO pandemic treaty, or now just basically revisions to their grand plan for global control, are not acceptable to freedom-loving Americans, those in independent practice. The WHO doesn't have any sets of competencies that would be useful to us. And while their report card on COVID is mixed, overall, they just simply did not help. But let me give you an example of mixed. The WHO correctly said not to use remdesivir in November of 2020. The sad news is that many countries didn't listen to WHO, including the United States, and remdesivir was given, and we suffered outcomes, including liver damage and kidney failure, no improvement in mortality. Another example where WHO was right, in June of 2021, they said no asymptomatic testing. Stop doing asymptomatic testing, getting on planes for workplace, sports, etc. They were right. The problem is no one followed them. WHO was deceptive and completely wrong on the origins of SARS-CoV-2. They were completely blocking any hope for early treatment. They did not support any multi-drug early treatment protocols, didn't seek out advice from anyone innovating. And I think the worst thing that the WHO has done is they have shown us they are fully a part of what we call the biopharmaceutical complex in our book, Courage to Face COVID-19. What I mean by this is that it's now fully recognized by multiple government agencies in the United States that the origin of SARS-CoV-2 was in the Wuhan Institute of Virology. And what we had learned is that Jeremy Farrar, scientific director of the Wellcome Trust, was in collaboration with Anthony Fauci and Francis Collins of the NIH. And they worked with Christian Anderson at Scripps, Edwin Holmes at University of Sydney, in a consortium to publish 12 fraudulent academic papers trying to mislead the world and tell the world the virus did not originate from the lab, but in fact, it came out of nature or out of a Wuhan fish market. You know what the WHO has done? They've brought on Jeremy Farrar as their scientific director. So I can tell you at this point in time, the WHO has lost all credibility. I know the World Council for Health has a major initiative now, giving, I think, a whole new bright set of suggestions of what we can do in public health response, but not rely on the WHO and certainly not cede any authority to that body.
Right. The World Council for Health has just released a policy on monopoly in global public health available on their website, worldcouncilforhealth.org, and is in the process of decentralizing to country council level. So it will be interesting to see how that impacts on real health and well-being. Dr. Jackie Stone, your colleague, has comment and input for you.
Thank you very much, Peter. That was brilliant as ever. I want to just make two comments, or one comment and one question. The one comment is that we know that both bind to the CD147 receptor, which causes hemagglutination in malaria. So one of the questions we're asking is why the antimalarials are working is because they're stopping hemagglutination. And we know that Marburg and Ebola have a viral, a cytokine storm, a thrombotic, and the D-dimer goes up 3 days before the platelets drop, and then they hemorrhage. So it's exactly the same pathogenesis. And we could follow your risk stratification and sequenced multi-drug therapy would work. The second question I would actually like to ask, because it concerns us here in Africa, is do you think if they rolled out a compulsory Marburg or Ebola virus, it could actually drive mutation and, like Geert van den Bosch said, create variants and make those diseases endemic in Africa?
Yeah, certainly. I completely agree with this idea that hemagglutination is central in the pathogenesis of these syndromes. You know, what makes a viral syndrome fatal is not the virus itself, but some pathophysiology that's tipped off, in this case, hemagglutination, the clumping of red cells, tripping off the coagulation cascade in a different manner than usual. Ultimately, platelets, fibrin, all play a role, but microthrombi and ultimately overstimulation of the thrombolytic system. So in Marburg, for instance, there's clotting and bleeding at the same time. In SARS-CoV-2 is largely just predominantly clotting. This is a central target. So not only these drugs, their ability to inhibit hemagglutination, but there's also a panoply of various forms of supplements that have some effect there too, that could ameliorate bromelain, N-acetylcysteine, and quercetin come to mind. So there's an opportunity for a multi-drug approach. You know, one of the concerns in the African countries, in Sri Lanka, India, these parts of the world, they have hemoglobinopathies. So they have hemoglobinopathies that could predispose to some problems, including hemoglobin S, hemoglobin C, the thalassemias, and the behavior of red blood cells with these types of genetic changes in hemoglobin, I think is a real wild card. They're much lower prevalence here in the United States, but I think those treatments certainly offer great help and offer great promise. And, you know, one of the things we've learned, and I think we're going to learn it with Marburg if we see more outbreaks, is we must start treatment early. And I think in these types of syndromes, intravenous hydration and volume resuscitation is going to play a role, because as soon as patients get dehydrated, volume contraction, this whole hemagglutination process worsens. We also know that oxygen plays a role. You know that when patients are hypoxemic and they're not given supplemental oxygen, then there's vasoconstriction within the lungs, and it can make the whole process even worse. So I think there really are some opportunities. I've been impressed with some of the doctors I've talked to around the world that have taken a more laboratory-based approach initially. In the United States, we take a clinical empiric approach, but the laboratory-based approach may really play a role. Hemagglutination can be visualized on dark field microscopy.
Thank you, Dr. Peter McCullough. I know that you're quite
Okay.
you're pressed for time, and we appreciate your time so much. But a few closing words of motivation for the public to take responsibility for their health and well-being.
I think it's absolutely critical now for everyone to be discerning. Just like in years past, people developed some expertise and understanding, various threats in their lives. We've gone through periods of time where water sanitation, other aspects of life were important. Now we have a whole new series of threats. And unfortunately, many of these threats are mankind, in a sense, influencing mankind in adverse ways, at least with SARS-CoV-2. So taking reasonable steps in understanding and having, I think, a real spirit of hope and joyousness that we can get through this together. All healthcare is always local. It's between the patient, their doctor, or their other care providers. It's administered locally. And in no way is healthcare amenable to a worldwide central authority. None of us are opposed to any of these central agencies helping out with outbreak analysis, data analytics, and in vitro diagnostics. But I can tell you in no way with the WHO's various types of statements or rulings ever influence practice here in the United States. I'm Dr. Peter McCullough. Thank you so much for having me on.
Thank you, Dr. Peter McCullough and Dr. Jackie Stone, for joining us in this episode of Pioneers.